Because not all control of the breathing is automatic, so we do have some voluntary control of our breathing, and that comes from the motor cortex of the frontal lobe in the cerebrum. And so that area is able to send impulses down to respiratory neurons in the spinal cord, and it bypasses the brainstem. So there's times that our voluntary control kind of takes over. But there are limits to voluntary control. So it's kind of like a system of checks and balances, really. So the limits to voluntary control is if the carbon dioxide level rises to a point that the automatic control has to take over. We know that we can't hold our breath indefinitely, and that's because that automatic system kind of kicks in. So they are definitely in balance. Okay, now we're going to talk about two characteristics, I guess, if you want to say that, that have to do with the amount of air and how the air is flowing, and that is pressure and resistance. So we're going to talk about airflow in regards to those two things. But here you're going to notice me skipping some slides. You're going to notice me simplifying, and that's okay. Your book goes through a whole chemistry lesson about gas laws. I really don't think we need all of that right here. So focus on what I focus on in these notes to study. So airflow is governed by similar principles of flow. So just like we talked about, blood flow is related to pressure and resistance. So again, this is getting into lots of laws, but here we know for the pressure, we're going to need a gradient, an area of high pressure and low pressure, and then we know what resistance is. So we're going to be talking about those two things and how they affect airflow. So atmospheric pressure is what drives respiration. So we're going to be comparing to atmospheric pressure quite a bit, and that's the pressure that's outside the body. Again, I'm going to go past some gas chemistry lesson. I don't think we really need that. So this talks about overall for inspiration, and again, I'm jumping through. Overall for inspiration, we have a pressure gradient. The atmospheric pressure at the nose is higher than the pressure that's inside the lungs all the way at the alveoli. So that is considered a negative pressure. There, I'm trying to get to, oh no, I went too far. Oh, I'm going the wrong way. Okay, so this talks about that the pressure at the alveoli is lower, and so that pressure gradient from the atmospheric pressure, this is all the way at the very bottom of this slide, the pressure from the atmospheric pressure to the alveoli is, it's only a difference of 3 millimeters of mercury. I know that probably doesn't mean a whole lot to you, but it is a pressure gradient. So the pressure, or the air, is going to move from a higher pressure to a lower pressure. And so this is how air is flowing into the lungs during inspiration. Now again, your book is going into interpleural pressure and lots of detail. I just want you to know that the pressure, atmospheric pressure at the nose or outside the nose is higher than the pressure in the alveoli. And this is how the air is going to flow down the pressure gradient, and that is how we inhale. The way I have this set up, I'm really backwards here. Sorry about that. Okay, then the opposite of that is expiration. This is the passive process which we talked about earlier about the recoil of those muscles compresses the lungs, and the volume of the thoracic cavity is decreasing. Well, not only is the volume decreasing, but that decrease in volume is going to change the pressure again. So before we had a high pressure outside the lungs and a low pressure or negative pressure inside. Well, once that volume decreases, that's going to raise the pressure inside the lungs. And so then the pressure inside the lungs is higher. Again, air is going to flow down the pressure gradient. And so at this moment, that is out of the lungs. Okay, so still always air is flowing down the pressure gradient. And in this moment is out of the lungs. Okay, some things that can happen that are abnormal for expiration. Just a couple of weird things that are possible. Pneumothorax, Pneumothorax is when we have air in that pleural cavity. Remember, that's the space in between the lungs and the outside of the thoracic cavity. If the thoracic wall is punctured, the inspiration would suck air through the wound and into that pleural cavity. And so then that space, instead of being fluid-filled, which is what it normally is, would be an air-filled cavity. And that would lose the pressure, and then we wouldn't have a normal expiration. Another option or another possibility is collapsing of part or all of the lung. This can happen from an airway obstruction. That's a possible link. So pressure is another determinant of airflow. We talked about that, and now we're going to focus on resistance. So resistance we've talked about before. Things that are kind of slowing down, the greater the resistance, the slower the flow, just like blood flow. And some things that are going to influence our resistance that the air is encountering in the airway is the diameter of the bronchioles. It can increase or decrease. Also, the ease at which the lungs can expand, which is called pulmonary compliance, and then the surface tension of the alveoli. So that surfactant is the substance that reduces the surface tension of water, and so sometimes that surface tension of the alveoli is decreased. So we need that thin film of water for gas exchange, which we'll get to in the next video. That creates the surface tension for the alveoli. And so pulmonary surfactant is produced by those cells, and that decreases surface tension by disrupting those water molecules bonding together. So this is going to go into alveolar ventilation, and to be honest, I think that you're going to need to understand the gas exchange part first before this makes a whole lot of sense. So I'm going to shorten this up quite a bit and just realize that only the air that makes it all the way to the alveoli is available for gas exchange, and that's not all of the air that we pull in. So only 150 milliliters fills, or about 150 milliliters fills the airway, but not all of that is making it all the way to the alveoli. So 150 milliliters stays in that dead space, and of the 500 milliliters that someone inhales, only 350 is making it to the alveoli. Sorry, I thought they were giving us our total number on that previous slide. That was my fault. So just realize not all of the air is getting to the alveoli. That's really what I want you to know, and that's going to make sense going further when we talk about gas exchange. So I'm going to pass through all of this math for you. You're welcome. And I'm going to keep going. It's just then very briefly at the end of this section talks about any type of obstructive disorder. It's just something that is interfering with the airflow by narrowing or blocking the airway. So if we know all of the air is not already getting to the alveoli, if we have kind of a blockage or something narrowing, then it's harder to inhale or exhale because we're not getting all the air we need. Some examples here would be asthma, bronchitis, emphysema. And we're going to skip past all of these. So again, in the previous video, we talked a little bit about some different rhythms. Our quiet breathing, relaxed breathing. Eupnea is about 12 respiratory rates per minute, or 12 respirations, I guess you could say. But then there's, some variations there. So sometimes we have apnea, which is when we stop breathing for a short time. We might have labored breathing or gasping breathing, or then an increased rate of breathing, maybe based on exercise, or hyperventilation, which is increased pulmonary ventilation based on an excess of metabolic demand. This goes over a few more. I think the ones on the first slide are more important here than these. These are a little less common.